Good morning, everyone, and my apologies for not being present in person. It is a great pleasure to welcome you on behalf of Sabin Vaccine Institute and walk you through the key challenges that childhood immunization has faced during COVID-19 pandemic. 50 million lives saved in 112 low and middle income countries during the past 2 decades is a huge testament to the incredible power of vaccines. Every $1 invested in vaccines fetches a return of $52 in these countries, making vaccines one of the most impactful and cost-effective health interventions. However, sadly, momentum is moving in the wrong direction. The Immunization Agenda 2030 has set a target of averting 5 million future deaths per year, but the actual number in 2021 was 4 million, down from 4.2 million in 2019. The number of zero-dose children has also increased by 37% during the pandemic, derailing the target of 50% reduction by 2030 and wiping out progress made during the past 15 years. And finally, all vaccines are far from targeted 90% coverage, HPV being the lowest, reaching only 12% of young girls. An important thing to keep in mind is that even before the pandemic, immunization coverage had stalled. Though during 2000 to 2010, coverage of DTP3 improved by 11 percentage points, it fell dramatically in the next 9 years, showing only a 3% further improvement. There was just 1% reduction in the number of zero-dose children, which means that immunization programs was struggling to identify and reach missed populations. COVID-19 pandemic made a further dent, leading to major reversals in all regions. There were very sharp declines in immunization in the second quarter of 2020, immediately after the pandemic hit, primarily because of lockdown restrictions, diversion of health workforce, and also fear among caregivers. However, immunization was also the first health service to bounce back in the latter half of that year, showing quite strong recovery in many countries, but was then hit by supply disruptions, particularly for PCV and Rota vaccines. The urgency relating to COVID-19 vaccination diverted attention from childhood immunization, though there was compelling data to show that sustaining childhood immunization would save the lives of more than 80 children at the risk of one COVID-related death. The scale and urgency of COVID-19 vaccination was quite unprecedented. I was at Gavi during that period, and we estimated that the global targets would require Gavi countries to deliver at least 3 times additional vaccination touchpoints on top of routine immunization if COVID-19 vaccines were to be received in time and in adequate quantities by these countries. However, as we all know, that did not happen, and COVID vaccines were supplied too late and in an unwieldy manner. As a result, countries had to first wait and then do a steep ramp up in late 2021, meaning they were now required to deliver up to 10 times additional vaccination touchpoints within a highly crunched timeline. Countries that are home to half of the world's children were still ramping up COVID vaccination in 2022. So the full impact on childhood immunization is actually yet to be assessed. Not surprisingly, both global institutions and countries deprioritized other vaccine introductions. And 2020 became the year with the lowest number of non-COVID vaccine introductions. Also, coverage of all vaccines dropped, except Rota. But important to note that Rota performance was heavily driven by the phased introduction and scale-up of the vaccine in India during this period. HPV vaccine is actually the one that has faced the most acute challenges. Countries with 60% of cervical cancer burden are yet to introduce the vaccine, and those who have introduced are struggling to improve coverage. School closures and continued supply constraints during the pandemic further exacerbated the challenge. As a result, global coverage for young girls has dropped, as you can see here, from 15 to 12%. A worrisome situation, given that more than 340,000 women are now dying of cervical cancer every year, mostly in low and middle income countries, far outpacing maternal deaths. Fewer introductions and coverage drops have led to a decline in the overall breadth of protection, which was previously showing a very encouraging upward trajectory and had actually doubled since 2000. As you can see here, immunization declines have hit low and middle income countries the most, and among LMICs, those countries that have transitioned out of Gavi support. This shows that progress can be quite tenuous, and backsliding is a real risk that we must gear up to mitigate. Africa is suffering from double whammy. It has high birth rates, and its immunization coverage is unable to get ahead or even keep pace with the increase in target population. On the other hand, Africa is also projected to have the largest shortage of health workforce, which, as we know, is a key driver of progress. In comparison, birth rates in Southeast Asia have begun to come down. The continent is also projected to augment its workforce quite substantially, which augurs well for essential health services, including immunization. That said, the pandemic has created enormous fiscal stress on countries, and it is estimated that nearly 80% of funding for COVID response actually came from domestic budgets. Countries are under high debt and unlikely to increase or even maintain their health budgets till 2026. So unlocking efficiency gains is going to be an important imperative. This would include reimagining service delivery to achieve much better integration and a pro-equity focus. Speaking of equity, zero-dose children, a concept that I created to shine spotlight on children who are completely bereft of routine immunization, remain our Achilles heel. Majority of them reside in Africa and Asia, but almost every country, including UK and USA, now have zero-dose children. The pandemic, as I said, led to a 37% increase in zero-dose. This means that more than 18 million children born in 2021 did not receive even a single dose of the most basic DTP vaccine and would also remain deprived of other vaccines, including PCV and Rota. 62% of zero-dose children now live in 10 countries. With the exception of Brazil, all of them are in Africa and Asia. In India, Nigeria, Indonesia, and Ethiopia, between 1 to 3 million children remain zero-dose every year. However, important to remember that several countries in Africa have a very large proportion of zero-dose children because of low coverage, but their birth cohorts are small. For example, between 45 to 50% children are zero-dose in Somalia, South Sudan, and Central African Republic. So it is important to focus on absolute numbers as well as proportion of zero-dose children. Urban slums, remote rural areas, and conflict settings are home to nearly 50% zero-dose children. These three contexts are also highly heterogeneous. and require very different service delivery models. For example, in Chad, co-delivering child and livestock immunization for nomadic population, something that we supported during my time at Gavi, actually increased coverage substantially, as cattle are the primary source of subsistence for these groups. In urban slums of Dakar in Senegal, changing the time of immunization sessions to late evening removed a major barrier for working mothers who were unable to bring their children during the daytime, and resulted in more zero-dose children being brought for vaccination. In parts of Nigeria, facing violence by Boko Haram, engagement of women groups and female leaders, supported by Sabin, has proven to be very effective in bringing mothers to temporary immunization centers in safe locations. Data shows that poverty, gender barriers, and ethnicity result in zero-dose children. 2/3 of zero-dose children live in extreme poverty in households that subsist on less than $1.90 per day. Mothers of these children are more likely to be uneducated and suffer serious gender discrimination. Ethnic and religious minorities are also more prone to having zero-dose children. For example, in this graph here, you can see that in Afghanistan, Nuristani is a disadvantaged ethnic minority and is home to an astounding number of zero-dose children. The pandemic has unfortunately increased poverty, created unparalleled food shortages, snatched livelihoods primarily from women, and exacerbated gender-based violence, migration, and displacement. Nearly 69 million people are now homeless, with many of them living in highly crowded and cramped spaces and camps for refugees and the internally displaced, which, as we know, are breeding grounds for vaccine-preventable diseases. Disasters and conflicts, including the Ukraine war, have raised new challenges, rendering the immunization situation quite grave in several countries, such as Afghanistan, Myanmar, Syria, Yemen, Venezuela, Lebanon, Libya, Haiti, Ukraine. We are also seeing the terrible effect of climate change. For example, the recent floods in Pakistan, which disrupted immunization services and heavily impacted women and children. Though 1 in 10 children were zero-dose prior to the pandemic, these 10% of children accounted for 50% of vaccine-preventable deaths, a disproportionately high burden. So efforts to bend the arc on child mortality can't obviously succeed without addressing this population. These children also suffer from multiple deprivations, including lack of access to water, sanitation, hygiene, nutrition, and education. The mothers are less likely to receive antenatal care and skilled birth attendance, highlighting the compounded vulnerability of these households. Accumulating millions of zero-dose children every year is an open invitation to disease outbreaks and spikes in child mortality. Both routine immunization and campaigns are missing these children, and as a result, we are seeing a resurgence of polio, measles, diphtheria. Be it disease elimination or disease control, success will continue to elude us if we fail to identify and reach zero-dose children. There is compelling evidence that 2/3 of children who receive at least 1 dose of routine immunization go on to become fully vaccinated. This is a very vital consideration to support laser focus on zero-dose children and get them started on their vaccination journey. Given that immunization progress is seriously off track, maintaining status quo or following a one-size-fits-all approach is no longer an option. We need a brave and bold approach to boost immunization by amplifying the involvement of communities, women, and professionals closest to service delivery, and by supporting ultra-local approaches that respond to the highly diverse and heterogeneous needs of countries and communities. That is our vision. and a key focus of Sabin's work. I thank you for your attention.